Thank you so much for having me. Can you hear me okay? Great. So I know that you had a talk on stewardship. This is a little bit of a different focus on rational antibiotic use, and I don't have any conflicts of interest. And the learning goals and objectives are a little bit broad, so this is too much of a talk to really do justice in an hour. So I'm going to pick and choose some things that our conference organizers really wanted me to focus on, and just some different classes of antibiotics and how to use them in common clinical scenarios that we may encounter in primary care. And then talk a little bit about some of the newer antibiotics, some of which you may never ever use, and that's okay, but you should know about them, specifically as it relates to some of the guidelines that just came out literally in July about how to treat our really resistant infections. And this is the whole point of stewardship, that we try to avoid these getting these emergent infections with organisms that are just really, really challenging to treat. So I'll touch on that as well. And so just so you're familiar with some of these things. So it's not a surprise that there's a lot of antibiotic use. And it is a struggle as a provider to sometimes say, no, you don't need antibiotics. And that results in a lot of antibiotic prescriptions. So about 300 million a year, most of which are in the outpatient setting, and not all of which are appropriate. And there's a study that looked at the appropriateness. And in this study, which had over close to 4,000 prescriptions that were reviewed, 76% of them were actually deemed not totally appropriate. One of the major reasons was maybe no antibiotic was indicated. And we'll talk about that as it relates to viral infections. You're probably seeing people that have COVID or think they have COVID, they test, and they're like, I don't have COVID, so it must be a bacterial infection. Can I get antibiotics? Or the wrong antibiotic was selected, or the wrong duration of therapy. I think for many years we were thinking more is better, longer is better, but that's actually not the case. And there have been lots of studies to show that shorter courses amount to the same outcomes without necessarily breeding antibiotic resistance or leading to toxicities. So you can see that there's some regional variation. We're not as bad in the Pacific Northwest here, as you can see. The top 5 states with the highest antibiotic use are clustered on the other end of the country. But you can see that these regional differences, Alaska with being the lowest prescriptions per population, and West Virginia being the highest. So there's clearly some targeted interventions that people can do to minimize antibiotic use for some of these areas. And then this is a map that actually shows narcotic prescriptions. And interestingly, it's the same places that have higher narcotic prescriptions as antibiotic prescriptions. So switching over to some of our common clinical scenarios that we see. Skin and soft tissue infections are something really common that people see in primary care. There's 2 flavors. There's cellulitis, which is not a purulent focus, where we just see mostly soft tissue changes without the purulence. Usually strep, but not always. Staph also can cause cellulitis. And then abscesses. So this is when there's pus that usually can be drained. And that can be MRSA, MSSA, and sometimes strep, but less often, leading to this more cutaneous abscess sort of formation. So how to cover cellulitis? In this study, there were almost 200 patients with non-cultured cellulitis. All were treated with beta-lactams, and all had acute and convalescent titer for strep. And 73% actually did have strep based on that criteria. And 96% had successful treatment with just beta-lactam treatment without MRSA coverage. And so we probably can get away more than we do with just treating with a beta-lactam and not covering for MRSA, unless there's a history of MRSA or there's purulence to suggest more of an combined abscess cellulitis sort of infection. So just saying, not all SSTIs or skin and soft tissue infection means it's staph. So in terms of management of our skin and soft tissue infections for non-purulent or cellulitis, and that spectrum can also include necrotizing infection, which can obviously is more severe, and we don't really see that in the outpatient setting, obviously. So I'll focus on the moderate to mild. And really what we're thinking in the mild situation where we see patients in the outpatient setting is doing a beta-lactam or clindamycin for those who are pen allergic or cephalosporin intolerant to treat those patients. And then for people that have moderate infection where you're considering admission or trying to stave off admission, giving an IV dose up front is a reasonable option. And then obviously for more emergent, if there's a necrotizing process, antibiotics are not the solution. It's actually surgical management. We do give, obviously, antibiotic therapy, usually quad therapy, for those patients to make sure that they're covered and also have an antitoxin sort of antibiotic, but we're not going to really focus on that here. So what about prevention of recurrence? There was a study done in 2013 that looked at recurrent cellulitis, about 274 patients, and giving them penicillin VK versus placebo, and they were followed for a number of years and looked at recurrence rates. And you can see there is a statistical significance here, but not a huge amount compared to the placebo. The recurrence rates were exactly the same once they stopped these antibiotics, though. So for our patients with recurrent cellulitis, we really want to try to understand the underlying anatomical reasons or other factors that may be contributing to their cellulitis to prevent that or to optimize those background factors rather than just throwing antibiotics long-term for them. A lot of patients do come to our infectious disease practice saying, I've had, 3 skin and soft tissue infections, and I'm sure you've heard this too in your practice. I just want antibiotics to take all the time so I don't have to worry about it. But that's not always the best solution because, again, you can breed resistance and then making it more challenging when they do have true infection to treat them with simpler oral outpatient options. Okay, so what about the purulent flavor of infections here? So abscesses, and so as you can see up front in terms of the management, IND is the #1 thing to do. So if you have pus, let's get it out. And that has been clearly shown to improve it. In fact, previously we weren't even doing antibiotics after an IND. And I'll talk a little bit more about that. In terms of empiric management, we really do want to have that staphylococcal coverage because staph is more implicated in these purulent infections. And so you can see here trimethoprim sulfa and then or doxycycline. And then you really do want to look at if they've had prior MRSA, what their or staph, what their susceptibilities were in the past. I do like to make sure that you get culture and sensitivity specific, more so for the moderate to severe infection, but also for recurrent mild infection, so you can appropriately give antibiotic therapy. Obviously, for the more severe infections, pyogenic infections, we can give IV therapy up front for those patients, particularly if they're getting admitted, and then de-escalate to oral therapy once you have that culture and sensitivity back. So in terms of abscesses, and this was a big study that was published in 2016 in the New England Journal of Medicine, looking at whether after an IND, whether you even need antibiotics or not. So patients were randomized to get 7 days of placebo versus trimethoprim sulfa. Like I said, they all got IND'd, and these were uncomplicated abscesses, so not septic, not requiring admission. So in the patients that received the trimethoprim sulfa antibiotic, there was 12% better outcomes in the modified intention to treat and per protocol, and you can see the results here. So based on this study, the recommendations did change to make sure that patients did get antibiotics after an IND because the outcomes in terms of less relapse in infection or worsening infection were present. It is, IND, like I said, is the gold standard for simple abscesses. There is a slightly better cure, but at what cost? I think the concern is, are we giving more antibiotics than we need for potentially mild infections, and then in terms of toxicity, and then again, in terms of resistance. So what about any new options? So dalbavancin not new, but I'm just curious, how many of you have given dalbavancin for skin and soft tissue infections ever? Okay, Jimmy, the lone, Dr. Chua is our lone person here in the room. Okay, and it's okay because he's an ID doc here, but typically we are not, even though this antibiotic has been around for a number of years now and it's FDA approved for skin and soft tissue infections, I would say most of its use is probably off-label from its FDA indication. I'm sure Dr. Chua uses it probably more off-label than for skin and soft tissue infections. It is dosed one time at a gram and a half or a gram, and then repeated at 500 milligrams at day 7. And you can see the price tag is quite large when we're talking about comparing it to trimethoprim sulfa, which is pretty dirt cheap. And then there are some things that you may be concerned about, like elevated LFTs, but that's actually not a super huge problem that we see. I think the main deterrent for using this for its FDA indication is the price tag. And we really reserve this for patients who may not be able to come back or have significant intolerance to, or allergies to other antibiotics that we would use in this setting. So I'd say the more off-label use is for bacteremia, endocarditis, more complicated deep-seated infections. And there is a randomized control trial actually for its use in bone and joint infections where it's dosed 1,500 and then 8 days later at 1,500. But for skin and soft tissue infections, I would say that it has a limited use despite its FDA approval. Similarly, iridovancin is another long-acting antibiotic in the same class. And it is also has an FDA-approved indication for skin and soft tissue infection. It is also quite pricey, and same challenges here for its use. So I'd say most of our use is off-label and not for skin and soft tissue infection. But as you will see, there are some other antibiotics that I'll talk about. It's easier to get these drugs FDA approved for these type of infections than trying to show that they work for more serious infections, and enrolling those patients is a lot more challenging. So we'll often see our newer antibiotics come out this way. And then when we have clinical experience with deeper infections, we use them more. This is just an antibiogram from our local data looking at MRSA susceptibility. And I highly recommend that you work with your local hospital group, clinic group to see if you have this data, because it's really helpful when we're talking about empiric therapy, specifically for skin and soft tissue infections where we may not have data for cellulitis. So it's really helpful if you have high rates of resistance for trimethoprim sulfa or doxy. Those may not be your go-to upfront drugs. Okay, so switching gears a little bit, what about vancomycin for pneumonia? So this is something that comes up quite a bit. Should we be covering more broadly for MRSA in our community when we see pneumonia? So this was a study that was published a couple of years ago that was a retrospective case series of quite a lot of patients with community-acquired pneumonia. And 38% of them did get MRSA coverage, but only 2% actually had clinical MRSA infection. So should we be using it? In terms of vancomycin, the adjusted risk and versus standard therapy, so there's 30-day mortality. There was more acute kidney injury, actually, and C. diff infection was present, VRE. And I think that's one of our big concerns when people are using, and you probably heard about that in other lectures, but the VRE emergence with use of more ubiquitous vancomycin. And some of these patients actually didn't even have a gram-positive infection, they had a gram-negative infection. So really thinking about whether patients need MRSA coverage with community-acquired pneumonia. How do we know whether we should pull that trigger? So in general, we like to not use widespread antibiotics for our patients with community-acquired pneumonia and really go for empiric therapy for our most frequent offenders for community-acquired pneumonia. There may be some things that would make us think more likely for to add MRSA coverage. Particularly in patients who are in the hospital, does this change? So there was another retrospective study, and patients didn't really have culture data to drive this, but they initially up front, they all got MRSA coverage in this study, in this retrospective series, and most also got Pseudomonas coverage, but they were de-escalated, quite a number were de-escalated, but still not a lot were. So I think when we add all of these up front for sick patients, we should really think about when we don't identify these bacteria about de-escalation. And you can see here the de-escalation versus no de-escalation. And what they found is that there was no harm in de-escalating from MRSA coverage, and that led to 3 days fewer in the ICU and 5 days fewer in the hospital because they didn't need that extra coverage. And so really thinking about this as a stewardship opportunity as well. So how can we know? What can help guide us? So this was a meta-analysis looking at 22 studies over 5,000 patients where they had MRSA swab data to help with trying to find the clinical microbiologic diagnosis. And what they found, and I'll point you all the way to the right here in the negative predictive value, if you don't identify MRSA in the nasal swab, it's very unlikely that this person will have a lower respiratory tract infection with MRSA. So if you have that data, or you can get that data, it's really helpful to de-escalate or not to add that as empiric coverage, particularly for patients who are in the hospital or ICU that are getting those swabs for routine surveillance, but perhaps even the non-ICU hospitalized patients where you can try to de-escalate when you know that it's not present. So again, when you look at the positive predictive value, just because it's there doesn't mean that it is the true cause of your lower respiratory tract infection. So if it's not there, it's really unlikely that it's causing a pneumonia. But if it is there, it's about 50-50 that it's your cause of pneumonia. So don't necessarily think I must continue the vancomycin for MRSA if it's there. So some other data looking at this in the VA cohort, looking at negative, and you can see again the same outcome here in terms of negative predictive value, quite high, not just for pneumonia, but all comers for blood infection, bloodstream infection. So if they didn't have it in the nose, it was unlikely that they had a bloodstream infection or an intra-abdominal infection with MRSA. Wound infections, not as high of a negative predictive value, but still pretty high at 88%. Okay, so what about our treatment for CAP in the outpatient setting when we're not thinking necessarily MRSA? So if there are no risk factors or significant comorbidities, or no risk factors for MRSA or Pseudomonas, then we can get away with a pretty simple regimen: amoxicillin, doxycycline, or a macrolide if there's not a lot of resistance in your area. If there is comorbidities like significant heart, lung, renal disease, and I would argue that many of our patients that we probably see have some comorbidity that's leading to community-acquired pneumonia, then combination therapy with amoxiclav or cephalosporin with a macrolide or doxycycline, or a monotherapy with a respiratory fluoroquinolone, which is your levofloxacin or moxifloxacin as the respiratory fluoroquinolone, and not a ciprofloxacin. And this is where there's been a lot of movement to decrease the duration of therapy. So for a long time, people were just treating for 2 weeks. Now we have data that show that 5 days is sufficient for these outpatient management of community-acquired pneumonia. We don't need to give long courses for these patients. For our inpatients who don't have severe, there's a bit of a approach here based on risk factors. So the standard regimen is still a beta-lactam plus macrolide or respiratory fluoroquinolone in your non-severely ill patients. But because they're being hospitalized, if there is a history or a nasal swab that shows that there's MRSA, you may want to add that MRSA coverage. And then the thought of de-escalation if it's not present in the lower respiratory specimen if you were able to get it. If they've had Pseudomonas before, then consider adding that and then de-escalating. Again, for recent hospitalization with antibiotics in the past, you want to try to use the previous culture data if you have that. So again, somewhat of an empiric approach up front, but if there's risk factors, looking at all their prior data to help guide your therapy and decide, do I need to add MRSA coverage? Do I need to add Pseudomonal coverage? For severe patients, we have a little bit more urgency to start pretty broad and then de-escalate. And so that's the main difference in the community-acquired pneumonia treatment if they're severely ill in the hospital. And again, you really want to try to get culture data if you can in these patients. That is going to help with de-escalation down the road. All right. Switching gears to another common problem, rhinosinusitis. I think this is something, because I do primary care for people with HIV, but I also do specialty care. And this is something that is really common in primary care practice. Adults have this pretty commonly. 98% of the time it's viral, but I would say 98% of the time people want antibiotics. I'm sure more of yes, people are nodding here. Only 2% are bacterial. Strep pneumo, H. flu, M. catarrhalis are the main offenders. Most of the time, people get better regardless of what we do, even if it's bacterial. And a lot of times people attribute that to antibiotics, but they probably would have gotten better anyway. No ironclad symptoms that can really distinguish between viral and bacterial etiologies. There are some predictors, for instance, if the symptoms have been present for greater than 10 days, that could mean that it's maybe more likely bacterial. And so it's really a lot of conversation to have with the patient to dissuade antibiotic use in these settings, though. And I think the diagnostic uncertainty really drives the antibiotic use. People really come in wanting to get antibiotics. That's why they come make an appointment. Otherwise, they could just symptomatically manage at home. And like I mentioned, we now have rapid diagnostics at home for COVID-19, but we don't have it for all these other viruses. So people just say, well, I don't have COVID. I must have a bacterial infection. And the diagnostics in a primary care practice are really not usually done like they are in a hospital setting in terms of the respiratory viral panel that we can send in a hospital setting, because they're expensive and you can't do them at home. So people come in looking for something when they come to the doctor. And honestly, even if they had RSV, we're not really going to do anything symptomatically for adults and for the most part. And so even rapid detection isn't necessarily going to be helpful in that setting, except if it's flu for a small subset of patients who may benefit from getting influenza therapy. So pragmatic approach, validation, sure, it's not COVID, but there are lots of other viruses going around. You most likely have one of those. And again, 98% of people with rhinosinusitis have a viral etiology. Good news, you don't need antibiotics. Try to phrase it very positively. Smoking cessation helps. So I always like to bring up smoking cessation at any opportunity. It's so good for many things, cancer risk, lung health, all sorts of things, but also to help with decreasing rhinosinusitis symptoms. You can take scheduled anti-inflammatories, analgesics, and judicious use of decongestants. Oftentimes people overuse decongestants and have more of a problem. And consider topical steroids or intranasal steroids if histories of allergies that could be triggering this. Vitamin C, people take emergency a lot. I don't dissuade it, except that it's sort of just you're peeing it out in your urine, and it's not really additive benefit for you. But if people feel better taking it, sure, power to them. But it's probably not doing anything to boost your immune system or help fight your rhinosinusitis. And appropriate hygiene and infection control are really important. And then neti pot. A lot of people use neti pots. I think people do get symptomatic relief from these. There is a caution though, because people were using not sterilized water, and there have been rare reports of free living amoeba infections, so Naegleria fowleri, that have led to fatalities, because obviously you don't want an amoeba in your brain, and they have been associated with neti pot use. So I personally don't like neti pots, but if people find symptomatic benefit from them and are using them appropriately with sterile water, then I think that's fine to use if they're helping their symptoms. So I like to avoid fluoroquinolone use if possible. I say that as someone who prescribes a lot of fluoroquinolones for deep-seated infections like bone and joint infections. I think they have their use, and they're very valuable drugs. But there is a black box warning on them for a reason, and it's to dissuade a lot of use in the primary care outpatient setting for more simple infections. So for sinusitis, first-line empiric therapy is amoxiclav. And again, we're not talking, sometimes people are like, well, I really need 3 weeks of antibiotics because that's what really works for me. I need longer because longer is better. Again, no, it's not better. 5 to 7 days, that's enough. Symptomatic management otherwise. And a lot of times, like I said, they don't even need them. Second line therapy, you can use doxycycline. Again, the respiratory fluoroquinolones are second line because we really try to avoid using these broad antibiotics with the black box warning. 5 to 7 days is sufficient. No longer recommended are azithromycin and trimethoprim sulfa. We may see some modified IDSA recommendations soon. I've been saying that for a while. The last ones were updated in 2012. With COVID, it doesn't seem like it's a super priority right now to update these, so we may see them in the next couple of years. Recurrent rhinosinusitis in terms of risk factors, some people bring up, well, what's wrong with my immune system that I keep getting these symptoms? I must need antibiotics for longer. Maybe I need to take antibiotics prophylactically. No, you don't. Beyond tobacco, there's probably nothing wrong. And if they don't, if they're a smoker, that's probably one of the factors. If they're non-smokers, it's probably allergy, environmental. But most of the time, it doesn't mean that there's a deep-seated problem with the immune system. If you are considering that they are because they have more significant disease or there are other infections that they're getting, and ENT has tried, and you've partnered with your ENT colleagues to really try to optimize their medical management, you may want to consider checking for CVID by checking IgG levels, or whether they have cystic fibrosis. Again, pretty rare to consider, but these are for, patients have really exhausted a lot of other options for management. Okay, switching gears to COPD and antibiotics for prevention. So how many of you have given azithromycin for prophylaxis for any of your patients with COPD? Okay, great. This is a study that came out that looked at, as a meta-analysis, that looked at using prolonged macrolide therapy to decrease the frequency of exacerbations. And so it's kind of a shared decision-making kind of option to weigh the advantages and disadvantages of use. And so there are lots of things that can trigger exacerbations that are not infection or not bacterial infection. And so here's a list of those things. Sometimes we can distinguish, there is a recommendation to use procalcitonin for distinguishing between exacerbation versus infection. Not everybody has in-house assay for that to help distinguish. but looking at other factors that may be contributing. And so things that we could consider as acute bacterial exacerbations for chronic lung disease. So do they have fever, cough, chest pain, dyspnea, increased sputum production, or purulence? Those things could be factors that would suggest bacterial, and specifically more of the sputum production and purulence. So the gold recommendations are, if all three of those are present, to consider antibiotics, and or if you have purulent sputum plus another, or if they're admitted and ventilated. And then in terms of treating these acute exacerbations, here are some options here. Again, respiratory fluoroquinolones are an alternative. Ideally, we like to use the more narrow spectrum, and again, shorter courses of therapy are preferred. And then if they're admitted, treat as community-acquired pneumonia. I'm going to skip over this because we really don't use this, and I want to get to our gram negatives, but you'll have this in the slide. This is in your slide deck, but this is a new antibiotic. I have yet to use it. I don't know, Dr. Chua, have you used it? I think the issue here is that it may have a role, but the cost is pretty prohibitive. For a course, it's in the thousands of dollars, and we have other issues, other options that could be used. So in the remaining time that I have, I actually want to focus on gram-negative infections because there were new IDSA recommendations, or Infectious Disease Society of America recommendations, that came out just this July, and really focusing on, these are the four horsemen, but these are our bad players here in ID that none of us like to see: extended spectrum beta-lactamase producing organisms, CRE or carbapenem resistant organisms, and difficult to treat resistant Pseudomonas aeruginosa. And I won't really talk about carbapenem resistant Acinetobacter in this. There are a lot of new antibiotics that are around. Again, these are really, there for a long time, there was not really options for our resistant gram negatives. And we had all these older drugs that were very toxic, like polymyxins and aminoglycosides, that we had to turn to, that were that were really not tolerated well. Now we have a bigger array, but again, we are using them very judiciously, and the goal is so that we don't get resistance to those things as well. So extended spectrum beta-lactamases are enzymes that inactivate our most commonly used antibiotics that I talked about, that we use for pneumonias and things like that up front, are penicillins, cephalosporins. And the ones that come to mind are E. coli, Klebsiella, Enterobacter as well, Proteus. And ESBL testing is not performed in most labs. And we have to kind of use a surrogate looking at our phenotypic, when they actually check the antibiotics against the organism in the lab, we can sort of use ceftriaxone as a marker. Oh, it's ceftriaxone resistant. That's kind of serious. That's usually our go-to drug for these organisms. And so could there be an ESBL? The guidelines that came out differentiate the preferred antibiotics based on the type of infection. So if it's an uncomplicated cystitis, we're not going to pull out the big guns. We're going to go with our, if it's susceptible, we're going to go with nitrofurantoin or trimethoprim sulfa. Usually I go with trimethoprim sulfa. If there's more resistance to those things, then we could think about fluoroquinolone as an option, and hopefully not go to the carbapenem right away, because we want to try to save those antibiotics and use those very judiciously. Fosfomycin is an option. It's really excreted only in the urine. And it's for E. coli only. Again, for uncomplicated cystitis, it is not recommended for complicated infections. If it's pyelo or complicated UTI, again, trimethoprim sulfa or our fluoroquinolones, and saving the carbapenems. If it's a non-UTI based infection, like deep abdominal infection, bacteremia, we're going to go with the carbapenem, because we don't want to mess around with our more serious infections. What about CRE? So this is a woman who has, so this is our carbapenem resistant organisms. This person has a urinary tract pyelonephritis, so more of a complicated in a woman with a lot of risk factors. So this is what comes back. You put her on cefepime because you're worried she's had infections in the past, and your E. coli susceptibilities come back like this. After screaming about it, freaking out, and calling your ID doc colleagues, like Dr. Chua, what would be the best thing to do for this? This is a pretty concerning. So all of our go-tos that I mentioned before, including carbapenem, it's resistant to. And we really try to avoid using our gentamicin and tobramycin, particularly in an 81-year-old who is definitely going to have complications from that. So CRE are really concerning. This is from the CDC, and you can see there's been sort of a little bit of an uptick, but there's a steady number of infections. It has not declined. And despite our antimicrobial stewardship and infection prevention efforts, this is an area that we really get concerned about. On the West Coast, we've been relatively lower prevalence of CRE than our East Coast colleagues, but still something that we really get concerned about. What happens with this is that the antibiotics, and there's three mechanisms, but one is that they make enzymes to chew up these antibiotics so they don't work. Another is they block the antibiotics from getting in. That's the pore. They block the pore. The antibiotics can't get in, so the organism is protected. Or the organism actively pumps out the antibiotic, called the efflux pump. These are all bad things that can happen to bacteria that prevent our antibiotics from working. So in terms of resistance to carbapenems, it's about 50-50. Carbapenemase, usually a KPC, or a porin deletion or efflux pump. And some of it you can see here is a pattern for CRE that you can see, and this patient had that, where you pretty much see resistance to everything. And you don't know what to do. I'm going to skip over this part. You have the phenotype testing that you can get in the lab. Some labs are able to look at genotype testing to look for those genes that encode for carbapenemase or these porin deletions or efflux pumps. The IDSA recommendations for carbapenem resistance, if it's again separated out by GU infection versus infections that are more serious, if it doesn't have a carbapenemase, so it's a porin deletion, then you can use some of these other antibiotics if they work in the lab, because these have different ways of getting resistance. So fluoroquinolones are our go-to, or trimethoprim sulfa in many of these situations. However, if it's an infection outside the urinary tract, we actually use prolonged infusion in meropenem. If there's a carbapenemase present, that's not going to be an option though. And then we have to go with some of our newer antibiotics that I'll briefly touch on in a minute. Similarly, if it's a difficult to treat Pseudomonas, then we also have the same sort of approach. Typically, Pseudomonas is already inherently a little bit more problematic than our other organisms because it already has issues that it has intrinsic resistance to penicillin and some of our other go-to drugs that we use for other infections, like macrolides, amoxiclav, and ertapenem. Ertapenem does not work for Pseudomonas. So this is what you see in this situation. Similarly, not looking like you have a lot of options. There has been a little bit of a dip in a multi-drug resistant Pseudomonas, but again, still something to be really concerned about. And particularly for patients with deep-seated infections that have not had adequate therapy, you can have an emergence of more and more resistance. When we just define difficult to treat Pseudomonas, it's actually resistant or non-susceptible to all of those antibiotics listed, which are usual go-to antibiotics for this organism. Again, I won't belabor this, but there's multiple mechanisms, as I mentioned. The IDSA recommendations that came out recently are preferred treatment. You can see some names that you might not have heard before for antibiotics. And again, if they're outside the GU tract, we're a little bit more aggressive, but you can see here all the antibiotics are sort of aggressive in this situation to try to really get rid of this infection. So here are some new antibiotics that you may have heard of. Ceftolozane tazobactam. And I'll just define this here as its FDA indications are for complicated UTI, complicated intra-abdominal infection, hospital-acquired bacterial pneumonia, or ventilator-associated bacterial pneumonia. The nice thing about this one is that we can use it for difficult to treat resistant Pseudomonas infections. And again, there's more and more clinical data we're getting on these antibiotics, but a lot of them had limited evaluation prior to FDA approval. Ceftaz AV is an Ceftaz we've had for a while, but it's combined with avibactam, which is an inhibitor of those beta-lactamases, and it doesn't have any antibiotic activity. This is actually good for CRE and for difficult to treat Pseudomonas. Meropenem, something that's been around, and again, the new additive is this new inhibitor that blocks these beta-lactamase inhibitors or beta-lactamases that these organisms have, so they can't be chewed up. The primary antibiotic can't be chewed up. And so this is for our CRE infections. Imipenem relli, again, taking an old antibiotic, adding a new inhibitor. And you can see that this one can treat CRE and difficult to treat Pseudomonas. So I would just want you to be familiar that there are these antibiotics that we have had new additives that can make them more powerful and add them into our armamentarium for these MDROs. Cefdiericol is a new one, not an old one reinvented, and maybe kind of the Trojan horse. We're really using it very limitedly, and it doesn't appear that the resistance mechanisms that some of the bacteria have really impair this antibiotic at all. We have some concerns about its use in terms of the data that led to it, but it is something that we have used in very limited ways judiciously for our very difficult to treat infections, and CRAB is our carbapenem-resistant Acinetobacter. Aminoglycosides, we all know, they've been around for a long time. I think we really try to avoid using them because of the issues with nephrotoxicity, ototoxicity, all the things that come with them, but they may have their place. However, you need to weigh in the benefit of these potentially new antibiotics that can be used and use aminoglycosides potentially as an alternative. Plazomicin, I'll just mention, it's a new aminoglycoside that gets around some of the issues that the older ones had. It perhaps is better. It's only FDA approved for a complicated UTI. There are some more studies ongoing to evaluate its use for more difficult or deep-seated infections, and it may have a role in some of these players. Polymyxins, I don't think I've prescribed a polymyxin in several years since we've had our newer antibiotics. They're horrible. Patients feel horrible on them. I won't even belabor that I'm talking about them, but they do work. And then there are some new tetracyclines that have been approved, eravacycline, for instance, that may have a role in treatment of these resistant infections. And we don't really know about combination therapy. Sometimes we think as ID docs, the more the better, but that's not always true. And so I think when we have really sick patients, there may be a role upfront of combination therapy and then de-escalating. So phage therapy, we're not in a place where we can talk about this ubiquitously, but there may be a role for bacteriophages, which are viruses that infect bacteria. It has been used in very limited ways, and it has to be done through kind of a study type setting. So I think I just want to leave time for questions because I went through a lot of information, and the take-home points here are de-escalate antibiotics when possible. Longer duration of antibiotics doesn't mean that it's better. And the MDRO infections or multi-drug resistant organisms pose a great challenge for us as infectious disease providers. Our bacteria outsmart them as we make new antibiotics, and each organism has its own idiosyncrasies. There are new drugs, but we always can get concerned about them not working, and also the fact they're extremely costly for patients, and we know that they're not going to work at some point. So antibiotic stewardship is key. Thank you so much. Happy to take some questions before your lunch break. I don't want to keep you from lunch.
Dr. Dhanireddy, thank you
Yes.
so much for your talk. This is Olympia Stafford. Hi. Was infectious disease in Tacoma, but I'm on the east side now. So one interesting, I want your take on a question. So you have a patient, they're in the emergency room with a UTI, and they had ESBL maybe in the past. So is giving them a gram of ertapenem the correct answer and see you in the morning?
Yeah, no, that's a great question. If you have a patient, I would say if you have the susceptibility data from before, I would utilize that data. If there's concern about complicated infection, I think giving them a dose, getting the culture, giving them a dose, and then keeping them from being admitted is a reasonable strategy. You may find that there may be oral options and to de-escalate therapy. Oh, yeah.
Hi. Question from Anita Hancock, a pediatrician, about your first-line therapy for rhinosinusitis. If it's an uncomplicated patient, antibiotic naive, why not just go with amoxicillin first-line therapy for somebody with 10 days of a wet cough and purulent rhinorrhea?
Oh, rather than just saying that it's...
Yeah, rather than augment. Second to last slide just said to avoid combination therapy. If that's going to work on most.
I think amoxicillin is reasonable if you're treating for a bacterial infection. Yeah, if you decide that you're going to treat for a bacterial infection, I think that's reasonable. Yes.
Can you hear?
Yeah.
Okay. You mentioned using doxycycline for infections. Very reasonable. However, I find that very often doxycycline and tummy, they do not cooperate. And so many people cannot take doxycycline with the severe GI problems. Is minocycline, which is often a little less reactive on the gut, is that a reasonable alternative to doxycycline if it cannot be used?
I think we have limited data on the use of minocycline in these settings, so that's why it's doxycycline. I agree with you. We use doxycycline for a lot of different things, actually. Chlamydia infection is now, it's recommended to use doxycycline, doxypep, which I think Dr. Kumbhakar will talk about in upcoming talk, is for prevention of STIs. We use a lot of doxycycline in ID, and I always caution patients about the GI symptoms, making sure they sit up at least 30 minutes after swallowing to avoid pill esophagitis. And also, because it's a lot sunnier here over on the east side, that there is photosensitivity with doxycycline. So people can get pretty bad sunburn or phototoxicity if they don't protect themselves. And so you're right, it's not a totally benign drug, but I counsel patients on that. And then if they have GI symptoms, I'm liberal with my antiemetic use as well for it. Yeah.
Emily Chow, pediatrician. You mentioned that for uncomplicated community-acquired pneumonia, 5 days antibiotic is the recommendation. Is that applicable to pediatric population as well?
Oh, that's a good question. I'm not sure. I will have to look that up and get back to you. That is in the recommendations from IDSA, and I have to see if it includes pediatric. I think the data was with adults that led to it, so I will check and get back to you. Anyone else know in that group here?
Question.
Yeah.
About patient with implantable devices and they develop cellulitis. What's your approach on those?
Oh, so like, are
With
you
the
thinking like a
total knee-
prosthetic
Yeah.
joint?
Yeah. I mean, not the site is infected, but the cellulitis is near those areas.
Yeah, and if it's like a distant surgery and we're not thinking it's a surgical site infection, I don't think I would change my approach. It's treating it for an standard skin and soft tissue infection. If there's any concern for underlying infection, then, I would evaluate. But if it's not a surgical site infection, then I would treat it like a typical cellulitis. Thank you all so much. I'll see you after lunch.